What? Are we live? We're live. Look at that. That means we're live.
Oh, wow.
All right.
Nice.
What up, snitches? Hey, let's wait for some people to come because I got to let these guys know. First of all, we got to give a shout out to our sponsor for the month, Athena Health. Athena Health is actually creating health IT solutions that actually help take the work off our plate. And these jokers may actually use the product, which was serendipitous but not necessary for this broadcast. We want to thank them for supporting this month. They want us to focus on physician burnout, and their whole motto is free up, so that if they can take some of this busy work off our plate and anticipate what we need, then we click less boxes and get to kick 70% more ass. And this has been quantified in multiple studies. Not a single study has been done. All right, that being said, Z-Pack, I want to introduce you. So I got to say, you guys know I've been traveling. Yesterday I was at the National Gaylord Harbor Resort in Maryland, and we did the talk this morning for the American College of Osteopathic Surgeons and the American College of Osteopathic Internists, about like 1,000 or 1,500 docs. And they were freaking amazing, you guys. Like, they were the best audience ever, but y'all are going to give me a run for the money because we have 6 docs in this room, and I am now in Trenton, mother-flippin' New Jersey.
Woo!
Hell yeah! With my crew from Capital Health. I'm doing a gig for them tomorrow. We did a little warm-up today. We did a couple songs. People were like, I don't know what to make of this. I'm so frightened. Tomorrow we're going to scare the crap out of them. But I said, okay, who are the coolest docs in this room? Let's go up to, whose suite is this?
This is my suite.
Jerry.
What's your name?
Jerry Gertzman.
Jerry Gertzman.
The coolest doctors couldn't make it, so
They relegated us. Jerry, what do you do? What's your specialty?
I'm a primary care doctor of family medicine.
Hell yeah. Thank you for your service, because it is truly a service.
Thank you.
And it is also a kind of a sacrifice, because you've given up the Porsche, the private jet.
And the boat.
And the boat.
Yes.
You could have a boat, Harry. A boat, Harry. Boobs and buttocks and beach, Harry. So Jerry Gertzman is our primary care doc. And what's your role in the organization?
I'm the director of the primary care division at Capital Health Medical Group.
Hell to the yeah. My boy with the evil Spock.
Ah.
Yeah.
It's all about the hair.
It is. What's your name and specialty?
So, Eric Schwartz. I am Executive Director of the Institute of Urban Care at Capital Health and responsible for our strategy in Trenton. So, you know.
So, back at the Institute, we study many things. We study stuff and more stuff, and then we get paid to do studying stuff. Is that the kind of institute you're talking about?
No, it's the power of these guys.
What?
That give the Institute the power.
All right.
Yeah.
All right.
The IT, the
I'm like
quality.
the situation Arcaro.
There
And I am also an internist practicing primary care, and I also work as the medical director of clinical informatics. So basically, the computer doctor who kind of helps with our EMR.
Wow. And what's your EMR?
It's Athena. We have Athena
Ooh,
Health.
serendipity, people. I couldn't have planned it this way. Like, they're sponsoring the month, and these guys actually use it, and you know what? They don't hate it. They don't actually hate it, which is a real relief, because if
Did you
they
get paid
hate
extra for that? Sorry. Whoops.
it... Hey, $5 is $5, dude.
Hey, you know.
Shut your mouth pipes, because
as
of
you share.
$5...
As long as you share.
You know what? $5 is going our way. We're going to get some pizza tonight,
All
because
right.
I hear we're in Jersey. So, Mike, the situation, tell me, you have a very odd resemblance to this gentleman.
So Mike was so busy that they had to clone him, and I'm the twin. So I'm Mark, not the situation, Arcaro, and I'm also an internist. So I do primary care medicine. I also am the director of quality for Capital Health Medical Group. So I help with all the quality measures that everyone loves.
Oh! Where's the Z-Pack at? Yeah, we already got a pinned comment from Tom. Tiffany Busby, I'm glad he didn't say Cerner. God, I hate Cerner. Oh, we can't take... We're not going to take craps on other health records. That's not what we do, Z-Pack. That's not very 3.0.
bullying.
Yeah, okay, but Meditech sucks. I'm kidding. Or am I? So we got Mike... Wait a minute. Mike the situation?
Yes.
Mark the conundrum. And you guys are actually twin brothers.
Yes.
You guys ever see the movie Dead Ringers with the twin Obie-Guynes? This is 70% more creepy. 70% more creepy than that movie. Amazing. And here at the very last but not least. Ooh, wait. Something's wrong with my gimbal. Oh, dude, it's behaving like a butthole. There we go.
There you go. You're going
What
to
you
my
got?
best feature.
Yeah, exactly.
I am Josh Eisberg. I'm a vascular surgeon. I also am the overlord of all these people.
Yep.
as the director of our entire medical group. I am the evil surgeon as it is.
I love it. Guys, I want you to notice something here. We have evil surgeon boss, twin evil internists, one of whom does quality stuff, the other does EHR stuff, like just bad all around.
Yes.
We got the poor primary care division guy who's like, I'm just here to like, oh God, why did I choose primary care? And then this guy
You got
at the
this
institute.
guy who's like, I don't know, just keeping an eye on them.
Yeah.
Actually, that's why I'm here, because...
And they're all smiling and kind of having fun, which means something's terribly wrong. And we're going to get to the bottom of that here. Let's take some comments. Mwahaha, Carrie Bennett says, evil surgeon. Are you really evil or surgeons evil?
Oh yeah, no, we're totally evil.
Tell me one of the evilest things you've done to another human being as a surgeon. Whether it's staff or colleagues or...
He cuts them open.
No!
Looking like a
Say it's not true.
It is actually true that as surgeons, I do cut people open.
Do you put them back together?
Not always. It depends on what time I got my tea time. You got to put your priorities first, right? Golf, family. I mean,
That makes sense. Golf and family. It's like the Bible Belt, except for golf.
that's right.
I love it. What one piece of advice would you give patients trying to prevent seeing you as a vascular surgeon?
Stop smoking.
Stop smoking.
Stop smoking.
Absolutely.
Single worst thing you can do.
Yeah. Why? Why is that? Why is smoking so bad for our vessels?
There are tons of. I mean, you're basically putting garbage and burning it in your mouth, and you're inhaling every toxin in the world for doing that.
I mean, that's like Taco Bell fire sauce, but I'm not going to stop doing that.
Well, I mean, look, you can't give up everything good in life. So
That's right. And then I heard something about pizza in this
Yes.
state. So tell me, what's the deal with pizza in New Jersey?
I feel like we are just south of New York, which is well known for pizza, but I think we do it better. We have the tomato pies in central New Jersey here, thinner crust, better sauce. It's really good.
So
Plus, we have the longest continually running pizza place in the country, right here in about 20 minutes east of here.
And it's not Little Caesars.
I have to ask you a question based on that. So you have pizza. Do you fold or not fold? And I would ask all of them. Like, how do people weigh in? Do you fold your pizza or not? I'm from Brooklyn. I fold. I'm sorry. But tell me, do you fold or not fold?
Well, they're going to tell us in a sec.
Yeah,
'cause-
I fold at the beginning.
Uh-huh.
I unfold at the end. You
Well,
need to savor
that's
it.
fine because, but at the beginning you fold.
At the beginning, you have
Do you
to
ever
fold.
see somebody like eating the pizza and it's dripping down? I'm like, I'm sorry. Like, I feel
How
bad.
about the knife and fork?
Oh,
Come
not
on.
the knife and fork.
No.
You know what though? I've switched over as I've gotten older, and maybe it's because I'm older. If it's really hot, I'll go to knife and fork just in the beginning. And I know it's like really wrong, but it's a way to eat quicker. I can
We
just
accept
throw
you
those
anyway.
pieces right in.
it's okay. We can accept you for who you are.
Okay, thank you.
This is what happens when you end up with like 6 guys in a suite in New Jersey.
Yeah.
Like, well, do you fold? It's totally hot, bro. I totally fold it. And I burn my mouth pipes.
You got to know when to fold.
Yeah, yes.
You have
Fold
know
has
when to
know
hold.
How much grease and how much stuff.
Exactly.
Tiffany
Totally,
Busby,
totally.
all caps, do not fold, says
Thank
Tiffany.
you. All right.
Tiffany.
Yes,
All right.
thank you.
And fold, says Bronx Pizza is the
No.
best, says Lisa Cosma. Who are these people?
I would love to know the final tally if you could. Zeke.
Oh, yeah, we'll know at the
Like,
end.
I would
Oh,
love to
we
share
will
that
know.
one.
And Tom Heineberg will share it with me, and I will share it with you. All right, now, speaking of sharing, part of the reason I've gathered this evil cabal here today, and I'm going to get a little space on us here. There we go. This evil cabal has been gathered here today to talk about burnout, damn it! Why are we burning out? What we can do to prevent it? What role technology has in that? And why nurses are so awesome and we're going to kiss their butts because we want our lives to be good.
True.
All of those things.
Sounds good.
Let's talk about that. So, burnout. Do any of you guys feel like you experience it, or do you still feel like you're living your calling purely without complication? And anyone can take this.
Definitely.
I've been in situations where I felt like
The
I was-
situation?
Oh,
Not the
oh,
situation.
Okay, good.
Next
Other
to the
situation.
situation.
Yes.
Where I felt like I was practicing medicine at breakneck speed.
Yes.
Here at Capital Health, we have achieved work-life balance. We only require our primary care doctors to see 2 or 3 patients an hour because we want them spending time with their patients and not burning out. We don't want to have a primary care doctor join us for 5 years and then leave and retire or go somewhere else. We want to nurture them and have them build a career and enjoy what they do.
So how do you do that when we're paid on volume, when we're paid on click boxes and how many 99217s or whatever we do?
It's hard to do,
It's a challenge.
but you can do more with a good EMR.
Oh.
And I know that Athena is the sponsor, and this is just a pure coincidence. I really do. And I realize I sound insane when I say I like my EMR. I really do like Athena. I love Athena. It's been life-changing.
What is different about, what's different about a good, forget Athena and all that, but what's different about a good EHR that you've experienced versus something that's less?
I've been on a bad EMR where it took 13 clicks to refill one medication.
Really?
Yes.
You counted these clicks?
I counted them because it wasn't right. It just didn't seem like that it should be that way. But it was 13 clicks to refill one medication, and here you can do it in literally 1 or 2.
Wow. And so it's a streamlining of administrative clicking.
Yes.
Is there a predictive component where it actually helps you make decisions?
Absolutely. I think the care management piece,
Mm-hmm.
the ability for the population health piece, that you get the availability of when a patient shows up, what do they need? Do they need a mammogram? Do they need a colonoscopy? Do they need a hemoglobin A1C? It's there in front of you at the point of care. That's what allows...
quickly parsing the chart, looking for, like with clinical decision support, and looking for those problems that, you're seeing a patient for a follow-up, you're seeing it for a physical. If it pulls in all those quick check boxes that you need to order and allows you to order them very quickly.
Yeah.
Like with a little arrow, pull them right over.
And that's what makes
a nice way to do it.
That's what makes Capital Health different than everybody, because we understand that at the base level. Just what you said. It's like, how do you make the most, of the experience? I mean, we recognize the value of patients' time. And when they come in, we know who they are. It's personalized medicine, and I think that's what we can
And you
do.
don't want to spend too much time looking at your computer and typing.
Right.
You want to spend face time with the patient, and so that they can have that connection with you. And you should spend very little time documenting and more time spending with the patient and getting to know them and understanding who their dog is and what their children are, what they do for a living, and what they like to do for fun.
You shut your mouth. That's not what we do in medicine. We click the damn boxes, and that's final. That's what we do.
Because these guys click all the boxes, and I get to see all their hard work, which makes my job really easy.
And it's nice because actually our specialists in our that we use oftentimes use the same EMR.
They benefit from us.
So they benefit because it's a global system essentially within our organization. Yeah, so that's a big plus.
And so you think this maybe has helped you guys become more efficient in terms of seeing those 2 to 3 patients, giving time to them, and then the computer maybe helps you. Because see, my whole thing with Health 3.0, which we talk about a lot, is Health 3.0 is repersonalized medicine, but how do you allow repersonalization? Oh, go ahead.
I was going to add one more thing.
Yeah.
I think we're focusing on the HR, but it's actually, I think workflows are key, and using support staff, having everybody work together.
Yeah.
So if you...
Wait a minute, are you just saying have the nurses click the boxes?
No, I'm not saying that.
Working well in conjunction with your nurses and your
That's
staff.
exactly.
Notice how they finish each other's sentences, by the way.
This is actually big. I mean, that
Dead
makes
Ringers,
more
that
of a
was the
difference
movie.
Than the EHR. It really does.
So it's the workflow and the
exactly.
team-based.
Workflow support.
Right.
Make everybody empowered to...
And Zubin, you said it
treat
before,
patients.
having everybody work to the top of their license. Everybody should do... Nobody wants to be a medical waitress.
Yeah.
A nurse wants to be a nurse. She wants to do patient care and patient education and take care of people.
She or he. Yeah.
She or he.
Yeah.
That's right. The nurse wants to take care of patients and not just take their blood pressure and escort them to the room.
So I like what you're saying, because I want to fill this in with the 3.0 angle, which is if you're going to repersonalize medicine and do what my boy's saying, because Jerry's like, I want to see 2-3 patients, get to know them, know their family, know their cat's name, know what their hopes, dreams, and fears are, know what their goals are for outcomes, right? And then help them achieve them. In order to do that properly, you're going to actually need technology to actually help you and then get out of the way. Instead of treating the chart, you're treating the patient. The second thing you're going to need is support team. So the full team where you mentioned everybody practicing at the top of their license, and that means nurses, pharmacists, RTs, nutritionists. The freaking housekeeper is practicing at the top of their game, right? They're calling as part of this mesh network.
So Z-Doc, what I did not hear you say was the patient. And you know what? You talked about...
That's because I hate patients. You know that.
Sorry.
It's about caregivers,
You're in
son.
Jersey.
Yeah, I'm
You're
in
gonna
Jersey.
call
I
it
got
out.
to... No, all right. You call it out.
What about the role of the patient, in their health? We talked about the whole team. If not for the patient, how are we going to do this? How are you going to do this?
So how... Okay, I hear And we're in Jersey, so we speak freely. It's not this California bullshit where it's like, let's beat around the bush and be nice to each other. Okay, you tell me, how do we empower patients without breaking our workflow, without turning a hospital into a hotel and being slaves to customer service? How do you empower patients? I want to hear your take because you're on the front lines.
Ah, apparently, yeah. So I think, when you talk about somebody with diabetes, you're like, you have diabetes. Maybe the question is, what does that mean to you? How does that impact your life? Because all we get is 15, maybe 20 minutes with somebody. They have to leave. It's their life. So I think if we can understand as physicians and as care teams, how does this impact your life and how can we help you, that changes the dynamic.
And how can we change their life to change the disease? Mm-hmm. So somebody with diabetes, instead of focusing on, hey, I'm going to treat them, I'm going to talk to them about their potential for completely, drastically changing their life to reverse the course of what they have. Because it's possible with many things in medicine.
Yeah.
Also empowering them by giving them tools like we have a patient portal. We're rolling out telemedicine. These patient engaging technologies, it doesn't work for everybody. And some people just want to be the patient and have you tell them what they should do. But there are others that will get involved more and more, and it's going to just benefit them because...
Well, can I give you a little bit of our experience at Turntable? So at Turntable, what we found is to empower the patient, you go where they are. Exactly what you said. What does it mean to you? What does the diabetes mean to you? What are your hopes, dreams, and fears? Also, how do you like to communicate? So we would tell patients, look, a lot of our sort of Spanish-speaking hotel worker, culinary union patients, these are the people who clean the beds, who make the food, that make Las Vegas run. Vegas strong, by the way, people. We would ask them, well, how do you like to communicate? They don't like telephone calls. They don't do email. What they do is text message.
Absolutely.
And that's what they do. And so we would say, okay, here's a form we're going to have you sign to opt out of the HIPAA piece, and understanding that these text messages aren't secure because we didn't have the money to build a text message again. Now, I have no idea if this is legal, but it felt right to my elephant. So we did it, and the patients loved it, and they would text us. And the thing is, it didn't drive us crazy because we want to know, we want to engage with our patients in a way that's meaningful and to actually prevent a visit that's unnecessary. Right? When we didn't have a copay, they could see us anytime. It was much better to really create a relationship that's ongoing with any communication platform that you can have. And I think that's a big piece of it. And spending time with them, having health coaches, having these. You guys have the Trenton Health team, right?
Yeah,
we do.
Can someone tell me a little bit about that?
Yeah. I certainly can talk about that. Get to be medical director for our Medicaid ACO. It's an opportunity of all the healthcare systems within Trenton, the FQHC Henry J. Austin, as well as the City of Trenton, to get together and implement programs to really address the needs of the entire community around chronic disease, diabetes. How do we get people to help themselves and put in systems to give them the opportunity to really be successful?
Yeah. Now, Liliana Cook made a comment that was pinned by Tom that said, watered-down patient portals are really just annoying to patients. They don't have enough access. They don't have the context. How do we get around that? You guys are the EHR
If they're
guys.
watered down, I think if they are intuitive, if they're built well, and you're at the mercy of your EHR company, honestly. But if the portal is fairly intuitive, the patient is kind of tech savvy, and you enable all the tools that are within that. So allowing for online scheduling, allowing for messaging, allowing, publishing their patients' labs to the portal, being transparent as you can with their care.
And sometimes there's a fear as a provider that if you enable a patient to message you through this portal, you'll be flooded with messages. But we found that doing that actually made our lives better, easier.
And it's better for the patient because the last thing they want to do is leave a voicemail on an answering machine to be answered several hours later. They can send a message through the portal. Our nurse sees it almost right away and then sends it to us almost right away, and they can answer. They get an answer quickly.
So Z-Pack, I want you to weigh in. If you've used patient portals, do you agree with what these young doctors are saying? I gave you that.
Yeah,
I gave you that.
Thank you.
Speaking of young, can you log into your phone because I'm gonna read some comments. So let me know if you agree with that, because I actually think a well done patient portal can actually transform care. Here's the thing though. Does it add to the inbox drama that we are all drowning in?
In our case, it doesn't.
I don't think it does.
Because we've created a workflow where people are working, again, to the top of their license.
Yeah.
And our receptionists and our nurses field those.
Yeah.
They handle the things that they can handle, and they pass on to us the things that they can't. and we'll weigh in and give a medical decision.
And you're going to get a call anyway. So if it's a message to the portal or a call, so be it. And that was a fear we had.
Yeah.
I think
and patients having access to their information can never be bad. Like,
right.
I mean, patients come in all the time.
Wait, hold on. I might interrupt you because I write in the chart, 23-year-old drug seeker here to manipulate me. I don't want them to see that. How do you deal with that?
I mean,
The truth hurts.
I think the truth hurts, right? Like, I mean, but I think that people come in all the time, and look, I'm a specialist, so they have some issue when they're coming. They're not coming for routine things, and they apologize all the time about going online or doing their own research or having talked to other people. But it's always, the more information, the better, right? The more they know, then I can spend more time teaching them the next things. Like, I can use the visit to try to get them to stop smoking, which they haven't really thought about when they come in with an aneurysm. Like, and so I can say, look, the real way you're going to keep your legs with peripheral vascular disease is stop smoking. Like, and now they're in a really stressful time in their life, and we have great studies that show that when you impact, you can change patient behavior at stressful times in their life. So the smoking cessation rates are really high when vascular surgeons talk about them. They do it the correct way. Like,
that's really fascinating.
It turns out physicians don't have power; they only have influence.
So
over people's lives. Wow.
Heaven forbid.
Imagine that.
And influence in human society is power.
Well,
because we're evolved to try to seek influence because we're social creatures, and influence means you don't starve. It means you're not extruded from the tribe. You're gonna be protected. So it's an innate sort of drive to have influence, but I think our influence being used for good is such a wonderful, powerful tool, and that's, I think, what calls us to medicine. Now, I have an interesting comment from New Jersey Safe Staffing Ratios. Do docs ever read care plans that nurses do, or is it really just a waste of our time and more clicking? I'm gonna. What do you go ahead? Let's go through.
Well, my goodness, I love nursing care plans. I think if I ever want to know exactly what's going on, I'll read the nursing care plan. So thank you. I just want to say that.
How about you guys?
I have to agree, but I think what happens is some doctors, and I have been this way myself, you're working so fast, you feel like you're so rushed that you skip it, and you shouldn't. You really need to read it because there's so much information there. But we also all need education on how to easily access those care plans.
A lot of times hospitals,
hospitals don't
file
they
in
file,
stupid
yes,
places.
exactly.
Like physicians have to do a chart in a certain way. So when
Yeah.
you put the care plan in some goofy section
That's
all
exactly
by
it.
itself, then it's sort of out of sight, out of mind.
Yeah.
Untapped
And the
value.
problem with having all
Untapped
this
value.
all this technology, but if we're not using it correctly, it just doesn't work.
So-
everyone has to
the
use it
informed doctor is going to know that the nurse is able to spend more time with the patient and have a rapport with the patient that maybe the doctor doesn't, and be able to get more information and impart more knowledge than the doctor could. So you need to take advantage of that.
So here you guys have it. There's 6 doctors here saying that the nurse care plan actually matters, but that it matters that it's actually available, that it's parsable, that maybe it's searchable, that maybe it's condensable. And I'll tell you, those of us who accept transfers from outside hospitals, sometimes they're only the nurse's notes that come through. And that's when, right? That you can read, because the doctors are like, blah, 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 blah. It's like from some non-EHR, community hospital. And you go through the nurse's notes and you learn so much, but you have to come at it obliquely because the way that our doctor brains work.
We're not trained.
We're not trained. We're not
trained to use the nurse's notes. We really aren't. In
We-
our
look-
residency and medical school.
Should we be? Should we do
Absolutely. We should be trained to be in a team.
Yeah.
Instead of-
3.0,
Yes.
doctors can think
Yes.
like
Yeah.
nurses.
Yep.
You know
Yep.
what? Sorry.
And
that's-
Heaven forbid.
Adding integrating rounds with the staff, like different staff.
Interdisciplinary rounds, yeah.
And we do that at Capital Health. In
Makes
our
a big difference.
hospitalist
We
team,
do that.
we have
Yeah.
interdisciplinary rounds.
So who is on that rounds team? Like what interdisciplinary are we talking about?
Well, it's
So here,
physicians,
Uh-huh.
and nurses.
Nurse practitioners or PAs,
Uh-huh.
the nurses, pharmacy, social work and/or case management, physical therapy. If they're in the ICU, respiratory therapy. Really, every aspect of
real
everything.
team.
Like,
Yeah.
Yeah.
Dudes, do you see the emergence? I always say this. I travel around the country and I see 3.0 emerging in fits and starts in places. And I bring my phone so that we can highlight the best ideas and some of the bad ideas too. But the idea is that if we as agents of change, frontline healthcare people, and these guys all are, right? Even if they're working in administration, heaven forbid, evil.
Yeah, we have a touch of dark side.
Yeah, hella dark side. That's right.
I'm trying to stay close to the light.
That's right. I like how he pulls his hands out with that force lightning. Yeah. He's like,
That's what's different about Capital Health Medical Group. We are physician-led.
Physician-led,
that
which
makes a big
Actually,
difference.
you know what? That's a big part of burnout. So, including the caregivers in leadership helps.
heaven forbid.
So-
I had Robbie Pearl, the CEO of Kaiser, on the show, and we talked about physician leadership or clinician leadership.
Clinician, yeah.
So
Exactly.
it's not just physician.
Yeah.
It can be a nurse. It can be an RT. Someone who's touched patients,
Yeah.
preferably in the buttocks, because that's where it gets real.
And it helps to alleviate the culture of providers having a little bit. There's always a little animosity with,
Yep.
with
A little.
administration.
There's more than a little.
But it helps to alleviate that, and that's important for all of us because we can work together as a team.
I agree. And Jody
That's another
Chance
part.
asks, should nursing and med students attend some classes together since they're going to have to work together?
Yeah,
Yeah.
That's a good idea.
And I
Yeah, it started early.
Yeah.
I used to teach the residents. One of the things I used to say, instead of like trying to figure out and go through all the things you got to go through in the chart when you're making your rounds, if you walk up to the nurse who's with the patient, and just say, "How's Mr. Jones doing?" They'll tell you everything in 10 seconds.
Yeah.
Like,
It happens
they know
all the
everything.
time.
They're right there. Right?
It
They know
happens all the
everything
time.
That happened all night long. So,
And you know, here's the thing about great nurses is they want to share this information. They're waiting to share it, and when they don't get a sense that the doctor cares, it's really rather devastating. It's like, why am I know so much about this patient. I'm spending my time with this patient and my 5 other patients because our staffing ratio is out of whack and so on and so forth. But you know, it's a thing. I'm going to try an experiment now, though. I'm going to hand these comments over to you and anyone who wants. You pick a
Because he's
comment
the
that you
IT
like
guru.
as we're talking, and what's that?
is it because he's the IT guru?
It's because he's the IT guru. It's also because it's his
While
phone.
he's doing that,
Yes, that's right. Yeah.
right.
And you can pick a comment that you like, read the name of the person, and then the comment anytime and interrupt us as we're talking.
Okay.
So we have new comment curation as we go. Now, the pinned comment at the bottom is what Tom Heineber back
all right,
at
I
the
can
mothership
look
is
at that.
pinning. Yeah.
Oh.
You don't have to read them, but whatever you think strikes your fancy or you think is something we
While
should
he's
talk
doing that, I'm just going to throw in props for our magnet status because we talked a lot about nursing, and at Capital Health, we're a magnet hospital.
That's right.
and that speaks to who we are. So I'm just
I-
giving you time to.
You know what?
I'm going to play devil's advocate on that real quick. So some of the nurses say magnet is a scam and it doesn't really do anything and it's just more click work. Is that true?
No, I don't think so. You just see it in every patient. You don't get ready for magnet, you get ready for the next patient, and I just see that every day.
Awesome.
So.
All right, my friend, what do you got?
So, what about care team plans instead of just nursing plans? This is a key point. So,
Who asked that?
this was. Oh shoot.
He'll learn. He's a doctor. It'll take him a while.
Disappeared off my screen.
That's okay. Yeah, they scroll. Yeah.
But anyway.
Someone else the phone now?
So anyway, care team plans. This is key because we just said nursing plans. It's true though. There's an entire team that's involved. So you can read physical therapy, occupational therapy, speech therapy plans, along with physician plans, along with specialist plans. It would be nice if everything was very intuitive in an EMR, where you could reference different things, where you can pull what you need out at the right time.
Almost where the notes could integrate into one
Yes.
note with little like you hover over it and it says who wrote it.
that would be
and,
nice.
And so we tried something like that with our EHR at Turntable, which was called the IORA Clinical Information System, or ISIS. That was a bad name.
Oh,
yeah, it was a
yeah.
very bad name.
Marketing.
They're clinicians, not marketers. So, but the idea was that everybody writes in the same note at the same time because we're not billing CPT, so we don't have to prove to Medicare or whoever.
Oh, see,
and so it was easy. So we just create a pastiche that's issue based, and everyone creates on it, and made it very good. And since it was issue based, you would just hit the part of the chart that if you're interested in the CHF, you could get right into that. But it's complicated. And the nice thing is there are health IT people that are working very hard to make this happen, to make it better. And we can't just take a crap on them, okay? Because it's easy for clinicians to do that. Oh, my God, clinicians should write this. Clinicians can't damn well code, okay? So we got to work with our partners. And these frontline people that are building the software actually care deeply about patient care. They see themselves as agents of patient care. And we should help them instead of, I know we're busy, but like these guys get together and they think about what would a better workflow look like? How could we drop the number of clicks? And they'll work with Athena or whoever and say, look, how do we make this better? And they're going to listen, right? That's what we want. Right?
And then just props for using the word pastiche.
You know what? It's a big word.
I just wanted to throw that out.
I went...
I
nice.
don't know what it means. So
Right,
if you
that
could,
was like
if you could
pastiche.
define that one,
That was great.
that would help.
Just,
a pastiche is a kind of a...
Is it a pistachio?
It's almost a collage. It's
Without
like
the shell?
it's like an all natural white pistachio, not those red ones.
All right, cool.
Yeah.
Right.
Smart. We're all doctors here.
Okay, yeah.
We all went to evil medical school.
Yes.
Several of us. Let's see. Nice shout out to the rehab, Mike.
Oh yeah.
That was from someone, Melissa.
The situation.
Oh, that's
Yes.
my sister-in-law.
Oh, that's your damn sister.
It's my wife.
Oh my God, that's amazing. You guys are dead ringers. Let's see. Let's read some other comments, my friend. What do you got there?
Oh, see, the bottom's the pin one.
How about some honesty?
Are Mike's parents watching?
Oh,
this?
some honesty. That's cold. How about some honesty? Hey, we're talking the truth here.
Yeah, no, these guys are.
really is.
Listen, this is Jersey. These people don't lie.
We're really not sugarcoating stuff here.
Yeah. What do you got?
Let's see. Well, someone said.
You gotta say who.
I don't. Oh, sorry, Erica Beth. I also don't want to email to deal with an EMR to email my doctor. If I agree to use email, they should be allowed to.
Yes, you want to use email. Patients want to use email.
They want to use direct email.
Yeah,
I know
they-
sometimes we struggle with that because of we're worried about HIPAA compliance.
Yep.
We're worried about if someone else accesses their email,
Yep.
could this be a problem?
Documentation too, because you want those messages in the system.
Yeah.
It's just, I mean, these are all.
But this is where big government just screws things up. You know what? If you gave somebody a note or a paper chart and they lost it, or they blew it out of the window of their car, then their HIPAA information would be all over the place.
Yeah.
So if they can't control their email,
That's a good point.
you know,
It's true.
It's.
How's it different?
I concur. I think this HIPAA thing has been a double-edged sword. It's great to talk about patient privacy and portability. Where did that go wrong?
Right.
Like what part of portable? There's nothing portable about HIPAA. It's less portable. You got to print that ish out and carry it with you, or send it by owl via Voldemort. Like it's the whackness, guys. So these are. It's funny too, by the way, watching docs struggle with reading these comments. They don't realize it's a damn skill.
No, this is very
it
good.
is.
This is a trainable skill.
Here's
Who's reading them next?
Kerry
Here's our
Phillips
leader.
says the only thing that's going to help is lower ratios.
So, what do you guys think about nursing ratios? Because this is a controversial topic, and a lot of administration, a lot of doctors are like, "Well, we need to work smarter, not harder." And the nurses are like, "Hell no! There's like 6 patients to a nurse. Like that's never
not
safe."
to toot our own horn, but in a Capital Health Medical Group in the outpatient primary care world, we have a 1-to-1 ratio. We have one nurse or medical assistant working with each doctor.
What about in the inpatient world?
The inpatient
Yeah.
world is
Inpatient,
different.
we don't.
And that's what's tough. We're
It's-
mostly in the outpatient, so
Yeah.
but we've been in the inpatient.
Can
Yeah.
I interrupt with another family member from Mike who wants
Come.
to chime in here? Anna Arcaro. Hi, Mike. We love you.
Oh, thanks, Anna.
All right.
You guys are the worst comment curators in the history of everything. I love it.
Reading comments and specific
Yeah,
shout out to
specifically,
Mike's
yeah,
family
shout
members.
Let me scroll to here. I'm gonna look at some comments here as well.
Noreen London, as an RN, I'm one of the nurses that keep the patients alive from doctors killing them.
Yeah.
Oh, ouch.
Well, you know,
Ouch,
look,
that hurt. That
look,
hurt a
look.
lot here.
You know what? It's fair to say when the doctor's an asshole and doesn't listen. It's not fair when we're just pointing fingers at each other because this goes both ways. Doctors will accuse nurses of malfeasance or negligence, and we just got to stop. What we have to do is go, how can we help each other help the patients? Like if it were a mom, if it were our son or our daughter in the hospital, like we would want to optimize the systems to do that, and that means better technology, better teamwork, better culture, better training, communication.
Make it about the patient. Make it about a just culture.
A just culture. That's interesting. I like that. Yeah.
It's, a process where everybody recognizes it's about the patient, and you build your systems so it's all about patient outcomes.
And Debbie Sadler, who I assume is a nurse, says if you guys act like you don't care, it is truly crushing. I've experienced this. There have been times when I've been really busy and a nurse tries to give me some really important information and I'm just like, and you can tell they deflate, and you know that the next time they're going to think twice before they share that information, and that's a tragedy.
Some doctors are assholes, and we're sorry.
Yes.
That's true.
That is true.
That is true.
Yes. Now I'm gonna step up and say some nurses are real assholes too. And
I did not agree with that. None of us agree with that.
We don't know who this guy is.
Check, please.
yeah,
He must not
exactly.
be practicing anymore.
I'm the guy. I'm the guy who doesn't round as much as y'all. Nurses know I love them.
agree?
I make videos for nurses. What the hell do you guys do? Nothing. You're just nice to them and respect them and like treat them as partners into care.
We gotta start
Okay.
making videos.
They don't want that. They want to see, what can I say except you're welcome for the nice chips, the med, the food. I'm kidding, guys. You know me. You know I love y'all. What do we got here? Carrie Bennett says truth. I don't know about what, but I like it. How can one properly take care of 26 patients plus Evelyn Clark? And this is what nursing home staffing ratios are like, right? And we saw those, sometimes it's like 1 to 40.
Impossible.
It's impossible.
It's not possible.
And they'll say, well, the patients are stable. No, they're elderly patients
Doesn't matter.
who have needs. And would you want your mom or your grandmother in a place like that? And that's how it is.
That's why, again, not to toot Capital Health.
Here we go, Mr. Capital
We
Health.
hired nurse practitioners to round in our skilled nursing facilities so they can take care of our patients after they leave the hospital before they can go home. And that nurse practitioner sees those patients 3 times a week and it develops a rapport and a relationship to keep that patient from getting sick again and having to go back into the hospital.
So how important are nurse practitioners, PAs, the so-called extenders or mid-levels, or these terms that
Those
people use?
terrible words for
Wonderful
Part of the
professionals.
team. Part of the team.
Part of the team. Part of the team.
You know, no better or worse than any of these guys.
So wait, do you agree?
100%. You can't do your job without.
And you agree.
Yeah,
And you
absolutely.
agree. And you agree. And you agree. So 6 out of 6 doctors agree.
That's better than
PAs,
dentists.
nurse practitioners, that's better than dentists.
Dentists are only 5 out of 5.
Are the ish. And now here's the thing, so I got in big trouble with the physician moms group for saying that nurse practitioners should be a practice at the top of their license. Yeah, no, it's okay. And top of the license doesn't mean that they should practice independently. It means that they should practice at the best of their training and ability on a team, right? And I got a lot of crap. And I think part of it is because sometimes there's a lot of bullying in the hospital. Nurses on young doctors, particularly female doctors, which I didn't appreciate at the time. Okay. And so there's a cultural thing, guys, that we have to really, if we're going to build 3.0, you said a just culture, I like that. I think a culture of compassion towards each other, like heaven forbid, right? Like surgeons are notorious assholes, but like some of the most compassionate people I've met are surgeons. So why can't we build a culture that's more compassionate? Like you can have psychopathic tendencies and be a surgeon, and that's great. But you can still like care about your colleagues and actually show them respect and not throw things in the OR and that kind of thing, right? So, I mean, this is true. And it's true for nurses who have the lateral violence in nursing, you know, the verbal abuse, the eating of the young, the horrible stuff that often happens. That's inexcusable. And it's true in medical.
2.0.
It's 1.0 minus, yeah. 2.0, what we would do is there wouldn't be lateral violence because we'd all just be clicking boxes and not talking to each other.
Right.
We would send each other like...
What? Is that
We sent
an
messages.
issue?
Yeah, is that an issue?
3.0 we're going to solve.
We're going to solve it.
Ashley Duska writes, Doc, speak to the hospital bigwigs. They listen to you. They don't care what the nurses say.
What do you guys think of that?
We have nursing leadership.
I feel like there is
in
a
our
lot of
system.
nursing leadership,
I just,
but
you know.
in some ways she's right because the hospitals fear the doctors because that's their
They're bringing in
that's their
revenue.
lifeblood.
Yeah.
You know?
Mm-hmm.
So it's a tough situation. I think we all have to get along. We all have to understand that everybody has different personalities, and just you got to try to work the best you
I think
can.
it goes to speak to the bigger issue, right? The patient doesn't get better unless everybody does their job well.
Yeah.
Right?
That too.
Yeah.
Yep, it's true.
Including them.
And that's really
Including
I
the
just
patient.
felt So
I'm
much of
the
the patient
patient voice.
experience.
Yeah,
though,
no,
you know?
including the
It's a
patient.
really so much of the patient experience has to do with the nurse. They're going to leave the hospital.
It does.
Oh, yeah.
And reflect on their experiences. How did the nurse treat me? How did I do during the day? Not for the 10 or 15 minutes that the doctor was there every day. But
Yeah.
how the nurses took care of them.
I mean, I think she makes a good point, though. I think a lot
She
of
does.
times we
Does
tend
make a
to
good point.
advocate for ourselves, like a more of a selfish approach as doctors, but we should also advocate for the nurses because
Yeah.
it'll help us and it helps everyone in the long run, and the patient especially.
So we
That's
were
totally
actually having an interesting conversation before about whether we would recommend our kids become physicians. And we're
Yeah.
talking about, the role of, physicians, whether you would encourage your kids at 2.0 or 3.0. And, a couple of weeks ago, I'm married to a physician. My daughter came home and said she wanted to be a nurse. And you know what? I could not have been prouder. So, nurses rule. Straight up.
Damn. I picked a kind of good group of docs, right? The others, they were all assholes. These guys are the cream. No, and this is just a representative sample. Like, if you're worried about medicine and, like, the general culture and you think doctors are buttholes and that and this, they're just not, like, this is what doctors ought to be. This is what doctors actually are. And the ones who aren't can STFU, all right? And since this month is about burnout and all of that, I think just talking about culture, talking about solutions to make things better, and talking to frontline people who are either working in administration or on the front lines or in IT or in the institute is is requisite to helping to understand where the future of medicine is going. Do we have any comments that you'd like to read?
One of the people didn't think I was in the screen enough.
Whoa, you got the Myers.
I just thought we should address that. Give me some more screen time here.
Now it's on. Now it's on.
Let's get the evil surgeon behind his skills a little bit here. Yeah, so, I mean, I don't know what to say.
I think I agree. I was like, and look at these guys.
Really nice hairdos.
Yeah, great haircuts. Let me borrow that phone real quick. I'm gonna see something here. You go ahead.
One of the things I was going to say that I think has helped us in our group is that we require all of our physician administrators to practice medicine still. We don't let you be just an administrator.
Yeah.
Definitely helps.
So I
Otherwise,
think that
no
keeps you
respect,
on the ground and keeps you doing things and
Yeah.
lets you understand the issues and battles that everybody faces every day. Otherwise, you become very separated very quickly.
You can't leave physicians unless you walk in their shoes.
Yeah, yeah. And you know what? They're not going to respect you.
Yeah, they won't.
Because we're like sharks. We sense blood and fear.
Yes.
Like if somebody's not there doing the thing, walking the walk, they can't talk. They can't talk the talk. We need New Jersey Safe Ratio says we need docs to help us keep patients safe. Yeah, our voice is important. We still now nurses are actually maybe more trusted than us by the public. But now you weren't in the frame before, but now you're just gonna be eclipsed by my bald head.
Now you just replace me with your head.
Hi, I'm a vascular surgeon. Let's see. What Susan Hilzebeck says 1 to 30 in a nursing home. Left the nursing home now in dialysis.
Wow.
So these ratios are tough. And mid-level seems like a derogatory term, says Anna Arcaro. They're very important, but PAs and NPs are not equal to physicians. So, okay, listen. Here's an interesting thing. PAs and NPs are not equal to anything. They are who they are. Just like doctors are not equal to anything, they are who they are. I agree with that. We all have our own set of skills, and especially in our emphasis. Like PAs are trained in the medical model, nurse practitioners are trained in the nursing model, and they bring a different angle, a different type of holism. Each of them is true but partial, as all of us are. So MDs are true but partial. We're really good at the medical model and instituting it. We're maybe less good sometimes at some of forming those bonds and relationships and looking holistically. We can be better, right? But we might sacrifice something in that way. So maybe we might sacrifice a tad of surgical skill because there's only so much time in the day. So we find what we're good at, and then we overlap with other people on the team that are good at other stuff. And that's where the emergent beauty of a system happens, when the system works together and all those complementary forces work. So I agree, and it's a good thing.
I gotta say, when patients come back to the office, I get more compliments about our PAs and nurse practitioners that took care of them than we do about the doctors.
Yeah.
That's true.
And and my dad told me that. He saw a nurse practitioner and he saw a doc, and he said the nurse practitioner spent time with me. She talked to me. And here's the thing. A lot of and there are docs who will be like, well, but they don't know. They didn't go through all this training, and they don't know this stuff, and they can make mistakes. Yes, this is all true. However, a lot of what we do in medicine, I think, is horse crap. I think we do a lot of stuff to people, not necessarily for them. And in the end, the data is going to show that maybe this stuff doesn't help that much. So sometimes just being there, listening to a patient, hearing them as a unique person is a crucial component of that. Now,
vascular surgery stuff all does help, actually.
Absolutely.
all of it.
Bright lights and stainless steel.
I'm going to get my veins stripped today, son. Jillian Johnson says, yes, see, the culture of compassion towards each other, boom. We all put our pants on the same way. We all want to see what's best for the patient. We still make a decent living, pay off student loans, and have work and home-life balance. We all want those things. Kudos to you amazing docs for trying to pave the way. Shit, yeah. High fives. Jillian, you're the bomb. You are the bomb. And now there's...
one of our Kara's relatives again?
Probably.
No, that wasn't. No.
Probably. What else do we got here? We are your eyes and ears, says Carol Grantham, referring to nursing.
Absolutely.
I agree.
True.
Definitely.
And hearts sometimes.
Yeah.
For some of us, because we're so busy, and they're the ones, Oh, someone was going to say
I
something?
was just going to say, what's our final word? I want to be so respectful of people's time to be able to share this experience and allowing us to share time with them.
He's trying to go and party.
He's trying to go.
He's like, okay, I'm done with this cast, son. So we're going to but you're right.
Yeah, true.
Yeah. So what
Actually,
is
one of
It's
the
about
things-
truth,
yeah.
right?
Jersey?
Yeah. That's,
Yeah. So to me, it's about the patient experience. We are physicians, but we're also patients, and we're husbands and family members, and it's understanding what both of those sides are and delivering the best possible care in a team-based approach that you can to,
And you should treat each patient like they are your family member.
They are your family.
How would you want to be treated?
And with each other, we got to stop the negativity. One thing that I hated always is seeing those, the grouchy doctor who says, I would never tell my kids to be a doctor. I hate practicing. This sucks. It's still a great field, good job security, and we work as a team.
And it's
with
a
nice
privilege.
people doing good
It's a
work.
privilege.
So
It's a
not
privilege.
many jobs
It
like
is a
that.
privilege.
So
Because
you gotta stop.
I think having that negative attitude leads to just worse. Like,
Toxic
Yeah,
work
it makes your job like if you have that attitude, you're not going to be happy no
Right.
matter what you're doing.
And ultimately, you're not doing the patient a favor by seeing them. They are giving you
Yes.
the privilege of taking care of them.
Yeah.
Sure.
And too many doctors don't think about it that way.
And I'm really concerned about how many Arcaro members are listening to this.
Ultimately, the
There's a
ultimate
few.
Do
truth.
not have anything else
That
to
is
do.
the ultimate truth.
This-
you know?
I'm now
A lot
starting
of
to question
Arcaros
how many
out
fans Z-Dog actually has that are
They're
not
all Arcaros. And then Tom Heineberg pinned his own comment. I'm Pickle Rick, which is a Rick and Morty quote because he's insane. Guys, like Mike, the situation, Mark, the conundrum, the whole crew. Just say your names one more time for my fam here.
Eric Schwartz.
Eric Schwartz,
Jerry Gertzman.
Jerry Gertzman.
Mike Arcaro, the situation.
The situation.
Mark Arcaro, the conundrum.
Josh Eisenberg.
And Z-Dog MD, it has been a thrill. We want to thank our sponsor, Athena Health, and these guys use their EHR, which was just coincidence, and they think it's 70% less crappy than other crappy EHRs. So that's a start. And really thanks to them, and thank to you guys. Hit share, hit like, spread the word, and wish me luck tomorrow. I'm going to bomb in front of these guys tomorrow. So
yeah.
they're
Looking
gonna
forward to it.
We're
They're
gonna
gonna
ask
hate
hard
it.
questions.
Oh, it's gonna be hard. No, there's no Q&A. I'm not allowed. You can do Q&A, and I'll just lie. We love you, Z-Pack. We out, peace.